Hi, everyone. Again, my name's Mark Goldberg. I'm the founder of Bonapeda. Today I'm here to discuss the Is Offloading insole, which for many patients has proven to be a superior offloading solution. As the incidence of diabetes has rapidly grown, numerous products and technologies have been introduced that promise to solve the problem of non-healing wounds and ulcers. And as you know, some of those solutions are quite expensive. And yet, evidence suggests that diabetes-related amputation rates are not declining, including for major lower extremity amputations. And in fact, amputation rates may actually have increased in recent years. The obvious question then, with all this money being spent, so why are DFUs so difficult to heal? Is it a bioburden management issue? Are we unable to clean and debride wounds effectively? Do we lack stuff to put on wounds? Do we lack effective dressings, advanced biologics, grafts, healing agents? Is it a diagnostic issue? Are you unable to assess whether or not a patient is nutritionally able to heal, whether or not they have peripheral artery disease, etc.? So based on the presentations at this meeting, I think it's fair to say that physicians are continuing to look for improvements to these procedures and modalities. However, it seems that underutilization of offloading continues to be a major culprit underlying the inability to heal many plantar ulcers.
The bottom line is you can't heal a wound without proper offloading. I often tell my residents I could probably heal half the wounds in my wound clinic if we simply just offload them the proper way, and we don't have to go with expensive dressings like biologics. We can just use a normal wound dressing and they'll get better. The longer these people have wounds, the greater the chance these people are going to have either a skin infection and osteomyelitis, or they're going to become septic.
I don't think there's anything that's more important than offloading when you're talking about a DFU. There are literally billions of dollars spent every year on dressings, grafts that are applied to patients, flaps that are done, surgical procedures, bone procedures, amputations, and none of them will succeed without offloading. If you take $1,000 tissue graft and apply it to a patient, you might as well throw the money out the window if it's not properly offloaded. Protecting the patient so that these grafts survive and making sure that, one, they're wearing the right device, and two, they understand the importance of offloading is essential.
So why is it difficult to keep weight off of wounds? And frankly, why is proven offloading more the exception to the rule rather than the rule? Physicians report patient resistance to restrictive offloading devices that interfere with their ability to work, their ability to drive, their ability to earn a living. I'm sure all of you have heard some of this. Some devices require being checked up on with some frequency and ultimately create copays that the patient can't afford. They put a strain on the family in terms of having to drive them to appointments. There are also contraindications to restrictive devices such as TCC. They can be a fall risk for some patients. Some patients are too heavy. The patients have an infection, drainage. You can't really rely on that patient to wear the device the way they're supposed to wear it. Some clinicians report restrictive devices such as TCC to not be practical for the practice. It's hard to maintain expertise. It's too expensive. It's too labor intensive. There's insufficient reimbursement. So let's talk a little bit more about the reimbursement question. The only method of plantar offloading that is covered by Medicare is total contact casting, and yet it's utilized for fewer than 10% of eligible patients. Shoe-based methods are reported to be used for about 30 to 40% of patients. And even though Medicare does not provide coverage for shoe-based methods, and there's little clinical evidence to support the effectiveness of most of these methods. So there are really two conclusions to draw from this data. One, apparently many plantar wounds are not offloaded. And two, if shoe-based methods are preferred, then proven effective shoe-based methods are needed. The Dfus insole is proven in multiple studies to provide effective offloading anywhere on the plantar surface. We'll talk a little bit about typical shoe-based offloading systems, which include cam boots. So cast walkers or cam boots, they may help offloading. They may help alter the patient's gait so they don't put quite as much weight on that foot. But they're flat. The bottom does not contour to the foot. They're not designed really for offloading. You can improve the performance with a customizable offloading insole. Similarly, post-op shoes and rocker bottom shoes, again, can alter the gait and ultimately reduce a little bit of weight on that foot, but they'll be improved dramatically with a conforming insole. Wedge shoes, half shoes, etc., they might help a little bit. They might help take some weight off the front of the foot, but they also present a fall risk to your patients, for many patients. Also, many patients don't walk on them correctly, and they haven't really been found useful for heel or midfoot ulcers. What about using extra depth diabetic shoes to heal ulcers? Extra depth shoes are not designed to heal ulcers. They're designed to prevent ulcers. Also, once an ulcer is healed, the rates of reulcerization are very high, approximately 40% within a year. And one of the key causes of reulcerization is that patients are likely going back into their shoes before the tissues had time to mature. Using a temporary shoe, such as a post-op rocker bottom shoe, a conforming insole, for a number of weeks following the wound closure may help transition the patients back into their permanent footwear with lower risk of reulceration. Also, if a patient presents wearing an extra depth shoes and they have a foot ulcer, that's an indication that those shoes failed and did not prevent an ulcer from forming in the first place. So using the same shoes to attempt to resolve an ulcer is problematic. So quite briefly, what's needed is an offloading approach that's effective, easy for patients to use, and that's affordable. The Dfus is made to fit industry standard post-op shoes, whether covered-toed or open-toed. They also come in sizes to fit cam boots. They reduce pressure by an average of over 40% on the targeted area. There's no edge effect. They're extremely durable. They'll last up to a year. They handle heavier patients, and they're cleanable. These two images were provided by Dr. Scott Schumacher. He's a US-based trained podiatrist practicing in Canada. He sees a lot of wounds. I ended up finding this on his website, canadianmaple.org, which stands for Canadian Medical Association for the Preservation of the Lower Extremity. In any case, he uses my product, likes my product, so took some pictures. This is my product after 5 months. This is a competitive product that fell apart within 1 month. This image over here came from a gentleman named David Freeman. He actually contacted me after buying this product on Amazon, and it didn't work out for him. He found out about my company, and we shipped him my product, the Dfus insole. And basically, after being successful with my product, he sent me these pictures, gave me the authorization to use them, and actually posted a review on Amazon showing what happened and saying that he was able to resolve the issue with my product. These are some posters and papers that have been published on my product.
The Dfus insole is very easily modified to address patients. It's also very effective. It automatically absorbs shock and pressure and contours to the foot. And that contouring allows it to shift pressure away from the ulcer to the rest of the foot surface. When we selectively removed the materials or the little pegs or pixelated sections of the insole out from underneath the ulceration, we were able to get upwards of, I think it was 54% pressure reduction at the site of ulceration.
My go-to is actually the Dfus, because I use that 90% of the time. The other 10% of the time, I use TCCs. I like the Dfus because, well, it's stable and it's easy to put on. You can pop those pegs out very easily. You can localize the pressure points. It's not time consuming to use. It only takes a matter of seconds.
It's a very simple insole to use, and it's made out of rugged materials, which maintain their offloading. The Force insole hold up a year. The materials it's made of make it very resilient. It absorbs the shock, but it doesn't mold or lose its ability to bounce back and then continue to absorb shock over time. That insole is a great insole. It just works.
I like it, the patients like it. And I must say, one of the ways I get them to comply with it is I threaten them with a TCC. And they don't want that because then they can't do anything or go anywhere. And plus, they have the fear of falling.
I mean, if you're going with a shoe-based system, I really think it's the best of all the insoles.
Using the fours is a simple decision. It's economically realistic for clinicians and their patients. The cost is $50 to $55 for the shoe with an insole. It's easy for physicians to dispense. The patients accept it. It's proven effective offloading, and it's durable and reliable. With the Fours insole, you can provide your patients with high quality, proven offloading that works for them. Some references. Thank you very much for your time. I appreciate it. Bye now.